Welcome to Pasifika Grand Rounds. We are with Dr. Samo and Dr. Kalani Raphael today. And after going through the slides to make sure that they're correct and they're edited, we are ready to go. So I'm going to turn it over to Dr. Samoa, and we're going to get through the introductory slides, and then Dr. Kalani Raphael will take us from there.
Give me one sec.
What's the dog's name?
All right, we can do the land acknowledgement if you want, or just the disclaimer, which is the content of this talk and all Pasifika Grand Rounds talks is provided for informational purposes only and does not intend to substitute professional medical advice, diagnosis, or treatment. Pasifika Grand Rounds is co-sponsored by Happy Doctors, Mapumaya, and Pasifika by Design. Pasifika Grand Rounds. Today we're going to be talking about kidney disease in Native Hawaiians and Pacific Islanders. And our special guest today is Dr. Kalani Raphael. Carl, you want to go through the his bio, or I can do it? And then
I will gladly introduce Dr. Kalani Raphael, who is an adult nephrologist and professor of internal medicine at the University of Utah and Salt Lake City healthcare system. Born and raised in Hawaii, he went to college at Gonzaga University and then attended the University of Hawaii John Burns School of Medicine. He completed internal medicine residency and nephrology fellowships at the University of Utah. His scientific expertise is in metabolic acidosis of chronic kidney disease, and his research is funded by the National Institute of Health and Department of Veterans Affairs. His other passion is helping Pacific Islanders and Native American students achieve careers in the healthcare sector as a strategy to eliminate health disparities in these communities. Welcome, Dr. Kalani.
Mahalo, Carl. Mahalo, Naki. Mahalo, Dr. Samoa, for inviting me. Mapumaya, Pasifikas by Design, and Happy Doctors. Glad to be here. Ray, can you share the slides, please?
Yes. Give me one sec.
And then we can do land and water acknowledgement. Land, we formally recognize the original stewards of the lands our institution stands on and their connection to it. The Gabrielino Tongva tribe are recognized as the original inhabitants of these lands, and their absence in the space speaks to the violent history they endured, including their forced relocation, enslavement, and exposure to old world diseases. This led to the rapid collapse of Tongva society ways and their eradication. We want to recognize our connection as the daughters and sons of Moana, the ocean that connects us, binds us to work together for better days for all our people.
I think because we have to switch which camera you have me on, because my screen is backstage.
Yeah, no, here we go. There you go.
Hey, look at me troubleshooting.
Hey, here we go.
Don't forget, this is your attendance code for CME credit. If you haven't set up an account, that's okay. If you email the code to the address below, cme@coh.org, they'll get you set up. That's our handsome presenter, Dr. Kalani Raphael. Take it away.
All right, mahalo. All right. So, it's a great pleasure to talk today about, a major health problem in our communities, and hopefully shed some light on some things that we're doing to try to mitigate some of these problems. So next slide, please. No financial relationships. Next. I think I'm supposed to say something regarding California law. I'm in Utah, so I'm not completely familiar with this, but the following cultural linguistic competencies and implicit bias components will be addressed in this representation. I'm going to be talking about cultural factors that impact kidney health among Native Hawaiians and Pacific Islanders, and the disparities in the healthcare workforce that contribute to health disparities in our communities. Objectives, going to discuss the state of chronic kidney disease, or CKD, among Pacific Islanders. Examine some of the factors that contribute to the kidney disease disparities in our populations, identify strategies to mitigate the risk of kidney failure, and discuss barriers and biases which may impact patient care, such as those on the screen. Next. All right, so I'm gonna start with a case of a young woman, 32 years old, Tongan female, referred to our kidney clinic at the University of Utah a number of years ago. And she was referred for a creatinine of 2.5 milligrams per deciliter and proteinuria. So just to get back to the basics for some folks who may not be in the medical field, creatinine is a blood test that we commonly get in the clinic, even when you go to your primary care provider. And this test really is how we gauge kidney function. A normal value is around 1, and higher numbers mean worse kidney function. So her creatinine of 2.5 indicates that her kidney function is low. The other thing is proteinuria, which is why she was referred to us. Normally, there shouldn't be any protein in the urine, and when there is protein in the urine, that's a sign of kidney damage. Okay, so that's why she was referred. Her past medical, could you go back, please? Yeah, thanks. Her past medical history, she only had hypertension for 4 years and a known diagnosis of diabetes for 4 years. She hadn't really been going to the doctor, so these conditions could have been present before, but that's the duration of her diagnoses. She had a hemoglobin A1C at the time of our visit of 7.4, which isn't too bad. That's a measure of how well your diabetes has been doing over the past 3 months or so. Generally, we want that number between 7 and 8. And she had no evidence that diabetes was affecting her nerves, a condition called neuropathy, or her eyes, a condition called retinopathy. Unfortunately, her mother also had kidney issues and developed what we call end-stage renal disease, or kidney failure, in her 30s and died in her 40s. So here we have a young woman with advanced CKD coming to our clinic. Okay, next slide, please. Her medication, she's on insulin, amlodipine, which is for blood pressure, simvastatin for cholesterol, sodium bicarbonate to treat acidosis that can happen in patients with CKD, and furosemide, which is a diuretic. On exam, blood pressure was not bad, 130/85, heart rate 89, BMI 33, no swelling or edema, and was otherwise normal. Next slide. So here are some of her labs. On the right, I show you the normal values generally for each lab. Some labs will be different, so keep that in mind. I want to highlight here that her blood potassium was 6. A normal is between 4 and 5, and anything that's 6 or higher is definitely concerning, and that's related to her kidney function being low. By the time we had actually seen her, her creatinine had gone up to 3.7. So again, higher numbers mean worse kidney function. And then this is the number that we really look at, the estimated glomerular filtration rate. That's a lot of words to basically say how fast is blood flowing through the kidneys. A normal value is more than 60, and she was down to 15. Generally, we start dialysis at a GFR of around 10, so that she's getting pretty close to developing kidney failure. And then the last thing I want to point out is that her urine albumin to creatinine ratio, which is a measure of how much protein in the urine she had, was 8,000, and normally it should be less than 30. So he has significant kidney damage from diabetes, most likely. Okay, next. So we're going to talk about chronic kidney disease. It's a very common condition in the United States. It affects about 15% of the whole population. That's a lot of people, 50 million people. The thing about chronic kidney disease, or CKD, is, as a nephrologist, I'm always trying to help people prevent worsening of their kidney function so that they don't end up on dialysis or develop end-stage kidney disease. But the fact of the matter is that most people with CKD will not progress to kidney failure, but they do have increased risk of death, cardiovascular disease, and hospitalization for a variety of reasons. Unfortunately, for those people who develop kidney failure, the average 5-year survival is around 40%, which is not very good. Now, keep in mind that this is an average, and there are certainly patients who have been on dialysis for 20, 30, even 40 years. So every case is unique, but this is, the average survival. And it's expensive. About 23% of the whole Medicare budget is spent on chronic kidney disease and kidney failure patients. Next slide. So how do we define CKD? Well, you've got to have low kidney function for at least 3 months. And generally, that's the GFR of being under 60, okay? There are some other cases where you could have CKD where your GFR, or that rate of blood flowing through your kidneys, is more than 60. And that is usually identified when people have an albumin to creatinine ratio, that's the ACR here, of more than 30. Other times we'll diagnose it by a kidney biopsy, or if we do an ultrasound that shows evidence of kidney damage. Most commonly, that would be something like polycystic kidney disease, which is a genetic condition that runs in families. Next. Yeah. So we classify CKD into 5 stages, G1 through G5. And we also look at the level of albumin or protein that's in the urine. And taking this 32-year-old woman, her GFR is 15 and her albumin to creatinine ratio is 8,000. This gives her what we call CKD stage 4A3. Okay, next. And so if we look at that and kind of use those numbers, we can actually gauge the risk of a variety of health outcomes in patients with chronic kidney disease. So here on the top right, you have all-cause mortality. And then on the middle panel on the left, cardiovascular mortality, kidney failure, acute kidney injury, which is acute kidney failure, and worsening kidney function. And what I've done here in these rectangles is show her risk of each of these outcomes. And because of how bad her kidney function is and how much protein she has in her urine, she's at extremely high risk of dying, developing cardiovascular disease, and developing kidney failure. Okay, next. And there's actually a calculator that we can use clinically to input that information, someone's GFR and how much albumin is in the urine, and that can give us a 2-year and 5-year risk of developing kidney failure. So these are her results, being a 32-year-old woman with advanced chronic kidney disease. In 2 years, her risk of kidney failure is 95%. And at 5 years, it's almost a guarantee. So here we have a really young woman who is going to be on dialysis, and that's going to really impact her quality of life and also the quality of life of her family. Next. So common causes of CKD are hypertension or high blood pressure. Diabetes is also, the main cause of kidney failure, but there are other things that can occur, like glomerular diseases. That's diseases that are affecting the little filters of the kidney. Too much use of drugs like non-steroidal anti-inflammatories like ibuprofen, celecoxib, and naproxen. Genetic conditions like polycystic kidney disease, urinary obstruction, say from an enlarged prostate that's causing backup of urine into the kidneys. Urinary reflux, which is a condition that typically occurs in kids, which causes urine to backflow into the kidneys as well. And then some hemodynamic factors such as heart failure and cirrhosis. And so if we do a biopsy on patients with diabetes, this is what their little filters would look like. And it's a little bit challenging if you haven't really looked at a lot of kidney biopsies before, but this is not a healthy looking glomerulus or filter of the kidney. Normally there should be wide open capillaries that you can easily see. And then on the bottom right is a patient who had his or her kidneys removed because of polycystic kidney disease, which is a genetic condition that ultimately leads to kidney failure in many patients. Okay, next. So in the clinic, we can do a bunch of testing to try to find out, what's going on with the kidneys. A lot of times we just make our best guess and say, oh, this patient probably has diabetes, and we just kind of assume that's what we're dealing with. But in a young woman like her, we want to make sure that we definitely, think about other causes, because she's going to have a lifetime cycle between dialysis and kidney transplantation. So we can do a lot of testing in the blood. All of this came up negative. And so ultimately we decided to do a kidney biopsy on her. And not surprisingly, it showed exactly what I showed you on that previous slide. She had advanced diabetic kidney disease, something we call diabetic nephropathy. And what we can also do with a kidney biopsy is look to see how much scarring there is, or fibrosis. And her biopsy showed that she had over 70% fibrosis in her kidneys. And that fibrosis is scar tissue, and it's just not going to allow the kidneys to recover to a normal state again. So next, I want to talk about how we can use certain types of treatments and medications to help preserve kidney function in patients with low kidney function. The drugs that really first came out as being demonstrated to preserve kidney function are these class of medications called ACE inhibitors or angiotensin receptor blockers. And these are some examples of those medications. Next slide. And here's the data to support this. And I want to call out that this trial was published in 2001, okay? That's going to be important for the next class of drugs that I talk about. This was a trial called the RENAL trial, where they tested this medication, losartan, and they looked at the primary outcome in this trial, which was a doubling of creatinine or worsening of kidney function, developing end-stage kidney disease, or patient death. And if you look at the top left panel in the solid black line, that's the group that was treated with losartan, and then the dashed line above that is the placebo group. And so what you can see with these results is that all of the outcomes were better for patients who were treated with losartan. And so this is why medications like losartan, lisinopril, and other drugs in those classes are really recommended for patients with CKD attributed to diabetes. So I like to just highlight that, if you have family members who are out there with, diabetes and high blood pressure or CKD, these are really good drugs for patients to be on. Okay, next slide. The new kid on the block is this class of medications called sodium glucose transporter type 2 inhibitors. And I say that they're new kids on the block. They've actually been around for probably a decade now, but we've really used them a lot more in patients with chronic kidney disease because of a few clinical trials that were published within the last handful of years. These are medications that are kind of fun, maybe from a nephrology standpoint, in the fact that the way that they work is they make you pee out glucose in the urine. And it's used to treat patients with diabetes. And here are some of the examples of these medications, like empagliflozin and dapagliflozin. There are other ones that are out there, but anything that ends with flozin is probably one of these drugs. And so the trial that really got the attention of the nephrology community was this trial called the DAPA-CKD trial, published in 2020, and the drug that they tested here was dapagliflozin. And again, similar to that other study, the main outcome was a 50% decline in the GFR, or the blood flow rate through the kidneys, kidney failure, or death from any cause, from renal or cardiovascular causes. And importantly, this drug was being tested in patients with chronic kidney disease, and they didn't necessarily need to have diabetes. So here we're testing a drug that is normally given to patients with diabetes, but in this case, it was actually used in both patients with and without diabetes. And so here, kind of following that other trial, the blue line here is the dapagliflozin group, and the red line here is the placebo group. And you can see that the treatment with this class of medications, SGLT2 inhibitors, really improved patient outcomes across the board of the outcomes that they were looking at, including kidney failure outcomes, death from cardiovascular events, or hospitalizations for heart failure, and death from any cause. So these are really the mainstay, in addition to the ACE inhibitors and ARBs, in the management of patients with CKD. Next. And then there was another medication that was shown to benefit patients with chronic kidney disease called finerenone. This one is not as widely used, but it's another player on the block that I really think is going to help a substantial number of patients with chronic kidney disease. Next slide. And here's the trial from for that drug. It was called the Fidelio DKD trial, published again in 2020. And I want to actually make the point now that, remember I showed you that first trial was in 2001. We actually did not have any new advancements in the prevention of, kidney failure in patients with CKD until 2020. So we went almost 2 decades really without any advancements. So there's really been, great strides that have occurred in the management of patients with CKD, in the hope that we can prevent people from, reaching kidney failure requiring dialysis. Anyway, back to this study. So this study tested this drug called finerenone. Again, the primary outcome was kidney failure. And following the same pattern as the others, the blue line here is the finerenone group, and the red line here is the placebo group. And these are the risks of kidney failure. In the top right is decrease of GFR by 40%. C is kidney failure, and D is a secondary composite outcome that they tested, which I don't recall what that is. But anyhow, in all of these panels, the patients who were treated with finerenone had improved outcomes or lower event rates. That's what we're seeing in all of these panels here. Okay, so next. So those are the 3 drugs that are being used a lot more these days for prevention of kidney failure. A lot of people are interested in these new class of drugs called GLP-1 receptor agonists, for example, semaglutide. There's a trial that should be posting results fairly soon called the FLOW trial, and we're all pretty hopeful that this medication, also used to treat diabetes and is commonly used as a weight loss drug these days, might also show that this medication preserves kidney function. But it's in parentheses on my slide because we don't know that for sure, but we are hopeful. Okay, next. The last couple of things, blood pressure control. So keeping the blood pressure around 120, keeping the blood glucose within a healthy range. And for a patient with chronic kidney disease, we generally accept a hemoglobin A1C less than 8%, avoiding those medications like ibuprofen, naproxen, those NSAIDs. And then if there's an underlying cause that is not due to diabetes or hypertension, to treat that. Okay. Next slide. Okay, there are a number of complications that can come up with when people have low kidney function, such as metabolic acidosis, which is a condition where your kidneys can't get rid of the acid that it needs to, and so you build up acid in the body. Sometimes we treat that with sodium bicarbonate. Other problems can occur with electrolytes like high potassium, such as our patient, anemia, which is low red blood cells in the blood, high phosphorus, high parathyroid gland levels, which is a hormone that is important in regulating calcium balance and bone homeostasis. And then ultimately, some people just progress to kidney failure. And one of the big things we have to do is try to prepare them for a life, where their kidneys aren't working and they need dialysis or a transplant to survive. So next. So I just want to show pictures of the 2 types of dialysis here. Basically, there's hemodialysis, which is dialysis that's done through the blood. So we take blood out of the body, typically from a fistula that's created by a surgeon in the arm. Blood comes out of the patient, runs through a dialysis machine where a dialysis filter cleans the blood, and we give the blood back to the patient. Typically, that's done 3 times a week in a dialysis clinic, although there are home options for that, and is a really good way to go if people are capable of doing dialysis at their home. The other type is peritoneal dialysis. This is done exclusively at the home, but this is done by having a surgeon place a long catheter, kind of a long bendy straw into the abdomen, where we fill the abdomen with this dialysate fluid here on the right. That fluid sits in the abdominal cavity for typically about 2 hours, pulls all of the toxins and things that we need to get rid of from the blood, and then we drain that fluid, and that's how we clear those things that the kidneys would normally get rid of. This is typically done at night, usually every night, while the patient's sleeping. And then lastly, those are dialysis types, but, ultimately we hope that every patient will be evaluated and ultimately receive a kidney transplant. And there's two main types: a living donor, which is coming from, say, a family member or a friend who is willing to donate one of his or her 2 kidneys to a recipient. And then there's a deceased donor. So for example, someone gets into a car accident, they survive long enough to make it to the hospital, but eventually they aren't going to make it, and their families decide to, allow that person's organs to be donated. And that's called a deceased donor kidney transplant. Okay, next slide. So these are some famous people who've had kidney transplants: Selena Gomez, Alonzo Mourning, George Lopez, and I'm not sure if many people know who this is, but this is Gary Coleman from that 80s show, Different Strokes, famous for saying, "What you talking about with us?" Yeah. So he passed away here. He was actually a patient here at our hospital. Next slide. So I just want to call out, that most famous individuals who get a transplant, don't always fit our demographic. And I want to just highlight that, we have some great ambassadors for people who have received the kidney transplant. This is Jonah Lomu, who was considered the Michael Jordan of rugby. He received a kidney transplant. He unfortunately passed away. But this is the Kemoeatu brothers. Chris on the left developed kidney issues while he was playing football. And his brother Maake donated one of his kidneys to him. So I just like to show that, yes, Pacific Islanders can and should get transplants and should really be pushing for that for their family members. Okay, next. So back to this patient, right? So, basically what I want to highlight here is that, because of advanced kidney disease, she's likely going to be on dialysis very, very soon. Her average mortality is 40% in 5 years. It's probably going to be longer just because she is, younger. But ultimately, what's in her future is a cycle of dialysis and hopefully transplant. Not all transplants survive for the life of a patient. They do fail. The average life of a transplant is about 13 to 15 years. And so with her age, even if she got a transplant now, chances are that transplant would fail and she would have to go back on dialysis. So, kidney disease, a tough one for patients and their families, but there are options to help these folks out. Okay, next. So I just want to call out Dr. Kikuni Blaisdell, who honestly set me on a path to become a kidney doctor or nephrologist. He was my mentor when I was at the University of Hawaii, and he took me to a dialysis unit at St. Francis Hospital, and I was shocked by what I saw. I mean, it was all Hawaiians in that dialysis unit. And if you know the demographics of Hawaii, right? Hawaiians are about 25% of the population. So to be filling up all of those dialysis chairs with Native Hawaiians, it didn't sit well with me. And so I wanted to become a nephrologist and see if I can help, mitigate some of these problems. So yeah, just want folks to know how important he was to me in my life. Yeah. Next slide. So, one of the most disappointing things for me was, like, I saw this disparity with my own eyes, right? That Native Hawaiians were really impacted by kidney disease to a much greater degree than other people in Hawaii. And, I wanted to look into, like, what is the actual numbers, right? What is the incidence rate? What is the prevalence rate? And really that data wasn't there. The place that we go to look for data on incidence and prevalence is this source called the U.S. Renal Data System. Basically, this is how we track kidney failure and other kidney-related issues across the United States. And most importantly, looking at trends in incidence and prevalence. They also look at transplantation rates. But when I first got into nephrology back in 2006, I looked for this data, and Native Hawaiians and Pacific Islanders were not shown in figures that are commonly used. And I'll show you an example of that on the next slide. It only was in 2011 that NHPI data were reported separately from Asian Americans in this data set. And what they found at the time was that the incidence of end-stage kidney disease in NHPI was 2,000 people per million, which is double the rate for African Americans, 6 times the rate for Asian Americans, and about 8 or 9 times the rate for white individuals. So this was really striking when it finally came out, and it was finally matching what I was seeing with my eyes, right? That there was this major disparity. Next slide. So here's an example of that figure that I mentioned where NHPI are not presented. This is data from the 2016 report. They have Asian, Black, African American, Native American, and white, and NHPI are not here. So there's a big invisibility problem, for a long time. Next slide. The following year, they did show the NHPI data in 2017. And what you can see here is that NHPI here are in the green line, and strikingly high rates of kidney failure shown alongside other groups for the first time in 2017. Next. There were some issues with some of that data, and this is kind of the justification for them not showing it. Basically, it boils down to the reporting of multiple race in the census versus the reporting of multiple race in this data set, the USRDS, and they don't match up. So we did a study where we looked at the incidence of kidney failure, including multiple race individuals. That's here in the dark blue line, compared to the incidence rates only looking at single race reporting. And what you can see over here on the far right, that even if you look at multiple race reporting, which will bring down the incidence rate, it's still higher among Native Hawaiians than Blacks, American Indians, Asians, and whites. So no matter how you crunch the numbers, really NHPI have the highest risk of end-stage renal disease in this country. Next slide. But unfortunately, our data still are not shown, even though it was shown once in 2017. This was the report from 2022. And again, NHPI are not included in these figures, which is extremely disappointing because it masks the disparity. Next. One of the issues is that race information is not collected well in the USRDS. This was a study where they scrutinized NHPI race by country of origin. And what they found was that a large proportion of people reported being from the Philippines. So that certainly impacts the NHPI incidence and prevalence rates. The point here is that data collection needs to improve so that we can track trends for our community in this really, severe disease that's affecting us disproportionately. Next. So what is the point here? The point is that, our data are often not reported, but they're there. We need to improve data collection, and data is super important because it maps health disparities, and it's uncertain to know what the health trends are unless we can see and track these data correctly. Yeah. Next slide. We need good data. We need accurate data. Why? Because it influences policy, right? I think the COVID-19 pandemic really made that clear when certain states were tracking COVID rates among the Pacific Islander population and showed that those rates were astronomically high in the Pacific Islander community. And that led to increased resources for a lot of community-based organizations to do some of this work. And so I think we all can see that data can be good for us, and we need it to help influence policy, provide resources, and tell us where to focus our efforts, and to tell us if what we're doing is working, right? And a really crucial part of that is that, NHPI data still needs to be disaggregated from Asian Americans. And I would argue that we need even more granular data, right? Down to Native Hawaiian, Samoan, Tongan, Marshallese, Yapese, Chukis, because there's a lot of heterogeneity even within Pacific Islander populations that I think we are mostly aware of. Next slide. So how do we get good data? We have to be proactive, and we have to advocate for ourselves. And I think that we have to partner with agencies that collect data, and we have to find policy change makers who can help us improve this data collection. And I think as I've become more attuned to this, I've gotten better at looking at slides and tables that reportedly enroll Pacific Islanders, Native Hawaiians, but they're grouped with Asian Americans, and that changes the numbers, and we have to really question, are we really there when we're being reported? Yeah, because we do need to keep disaggregating our data. And I think we should start collecting data ourselves, right? CBOs are doing a great job of this, and we should encourage them to keep doing it. Next slide. So back to this case, next slide. Yeah. Ultimately, diabetes was the cause of her kidney failure. I think a lot of us in the Pacific Islander community have, close family or friends who are on dialysis, most likely from diabetes. And really, diabetes is a major problem in our population, right? These are the age-adjusted percentages of adults who have diabetes. On the left here, you can see that for NHPI, it's about 20. For whites, it's 8. And so that gives us an incidence ratio of about 2.5 times higher risk of diabetes in Pacific Islander populations. So it's something that we need to address. Next slide. But even if you look at, individual Pacific Islander populations, right, there's significant heterogeneity, right? With Samoans having the highest percentage of diabetes, 22% of all Pacific Islander groups. Native Hawaiians, 14%. Pacific Islanders, a very broad term, 17%. Chamorros, 15%. So we have to recognize that there is some heterogeneity even within our Pacific Islander population. And I think that's how we can begin to tackle that, by addressing what's happening in each of those communities that's affecting the prevalence of diabetes. Next slide. I don't think I really need to spend too much time on this, but diabetes is a major reason for death for Pacific Islanders, right? It's 3.3 times higher risk of dying from diabetes. Other things that are sort of related to that include CHF, coronary heart disease, and stroke. And you can see that here in these orange bars. Pacific Islanders have higher rates of both dying from diabetes as well as conditions that are caused by diabetes, like cardiovascular disease. So we really need to tackle this in a systematic way. Next. I want to call some attention to this study, which starts very soon. It's an epidemiological cohort study of Asian Americans, Native Hawaiians, and Pacific Islanders, funded by the National Heart, Lung, and Blood Institute, with other support from the Human Genome Research Institute, Neurological Institute, Minority Health, and Mental Health. It's going to be a really impactful study, I hope, where about 2,000 NHPI in Hawaii will be enrolled to really kind of identify some of the main risk factors for heart disease, diabetes, other factors that affect our communities, in the hope that we can move forward and, get some movement in this area, really, to address some of the major health disparities affecting Pacific Islander communities, including kidney disease. Next. Lastly, I kind of want to touch on research. So I'm a researcher. I have grants from NIH and the VA, to do research. And I firmly believe that science can help us. We were scientists before, right? I don't think that there's any question that we were experimenters, navigators, right? Learning new things. And I firmly believe that even Western approaches can help us. But the fact is that NHPI are vastly underrepresented in research. And while there have been advancements in other communities, because we are not included so much in those research efforts, NHPI, I think, have not benefited from some of those advancements in the scientific community. Next. And I'll call example to this gene that has been linked with kidney failure in African Americans. This is called the APOL1 gene. And there are 3 different alleles or versions of this gene, right? These are not really mutations. They're just different versions of this gene. The normal, I'll put that in air quotes, is called the G0 variant, okay? The abnormal variant, as it relates to kidney failure, are the G1 and the G2 variants. And studies have identified that people with 2 variant APOL1 genes, interestingly, are protected from African sleeping sickness, but they have a higher risk of kidney disease. And that is likely explaining the very high risk of kidney failure among the Black and African American community in this country. And so I just want to call that out with, investigation and scientific methods. Maybe there's an opportunity for us to identify similar variants that are occurring in the NHPI population. Next. And actually, this is some exciting research from the University of Utah by my colleague here, Dr. Marcus Pezzalesi, who has identified a potential gene linked with kidney failure in NHPI. He found this by identifying a couple of Tongan and Samoan families in Utah who had a high prevalence of kidney failure. Through genetic studies, he found an abnormal gene, again, a variant, not really a mutation that's leading to an issue, but an abnormal gene in that's called this ASA2. Okay, it has something to do with sphingolipids, which Ray probably can talk to us more about, but it is thought to play a role in metabolic disorders, including diabetes. And as far as we know, this gene variant is only in Tongan and Samoan people, and its prevalence is about 10%. Now, again, this is not really a mutation, but it's a variant similar to what I described in the APOL1 gene in African Americans. So the question is, why would this variant show up? We don't know, but there's this variant out there with a high prevalence in a couple of families of Tongan and Samoan descent who have a high risk of kidney failure. Next slide. Now, please don't quote me as saying this is a gene that's causing kidney failure. We really don't know yet. This is some preliminary data that's come out of this work. We don't really know if it causes kidney failure. We don't know how. We don't know if we should check for it. But it may lead to strategies down the road if it pans out. Could we use it to screen people who are at higher risk of kidney failure? Can we use therapies that might help prevent kidney failure in Native Hawaiians and Pacific Islanders who have this variant in the ASA2 gene? Still a lot of work to do there. Next. And this has been the impetus to create this Utah Pacific Islander diabetes study, where we want to learn more about this variant. What is the prevalence in our Pacific Islander populations? Does it extend to non-Tongan, non-Samoan families? And further investigate what potential role, if any, it might play in the pathogenesis of diabetes and diabetic kidney disease. It's a quick study. People do one visit, and it's been quite successful. We've enrolled over 600 people here in Utah, really through targeted attendance at community events and community outreach. We've developed a lot of great partnerships with community-based organizations here, where we go on table and we screen participants. And there's been a great level of enthusiasm for participation, which is fantastic. Next slide. And part of that enthusiasm is because of our students, who I'll talk about in a couple of slides. This was participation of our students here at one of these screening events. And you can see that they're Pacific Islanders. So these Pacific Islander students were training to do research. They go to the events. They're a familiar face for the people in the community. And I think that it really has helped us be successful in recruiting people to learn what are the underpinnings of diabetes and diabetic kidney disease in Pacific Islander populations. Next slide. Now, please don't misinterpret what I'm saying. I'm not saying that Pacific Islanders are genetically predisposed to developing diabetes, because we know that this is a modern disease, right? We know from the historical record that diabetes was not a big problem in Pacific Islanders before Western contact. But what could be happening is that there might be genetic predispositions that were unmasked with acclimation to a more Western way of living, such as the Western diet. So it's a complex interaction between genes, potentially, and the environment, right? I think we would all agree that most of the diabetes that we see in our communities is probably not related to genetics. It's mostly related to other factors, but there could be something that is increasing the risk of complications due to Westernization of our people. Next. And just to point this point out, right, while there might be some genetic component, there are obviously other things that we have to keep in mind that are probably much larger players in the diabetes and kidney disease disparities in our communities, right? Such as land displacement, lack of culturally concordant providers, poor patient-provider communication, the list goes on, right? And even we must acknowledge that even though we group NHPI together, there is heterogeneity among all of us, right? There are different experiences among Pacific Islanders in the Western Pacific compared to the experiences of Native Hawaiians in Hawaii. And even us on the continent, right, who maybe were born here or moved here and live under different circumstances than individuals out in the Pacific. Next. You know, it's dinner time. You might be getting a little bit hungry, but I do think that, you know, we have to acknowledge diet, right? It's kind of the Pacific Islander diet now, right? certainly not what we were raised on before Western contact. And, I think people see this as our natural diet, right? The Pacific Islander diet. But I think we have to remind them that this is not the cultural diet, right? Next slide, Ray. This is the cultural diet, right? Kalo, breadfruit, right? Seafood, coconut, fruits and vegetables, right? So I would really love us to really try to move away from some of these more westernized foods, because I think that is playing a big role in some of our health issues today. Yeah, it's not always easy. Chicken katsu now and then is okay. But yeah, next slide. Lastly, I want to talk about some action areas. I think community health workers are doing the majority of work to help reduce health disparities. I would like to see more telemedicine going out into the Pacific. We talk about policy and data, research and mentorship. Lastly, I want to talk about the healthcare workforce, because honestly, in my opinion, that is going to be the best way that we can mitigate a lot of these disparities. Next slide. I'll just show you this one slide. This was data from a paper looking at the deficit of physicians across race and ethnic groups in the United States. And I just want to highlight here in this gray bar, this is the deficit for Pacific Islander physicians in the United States in 2015. In 2010, there's really not enough data to talk about there, so let's just focus on 2015. Thanks, Ray. So this is the deficit in terms of numbers of physicians per 100,000 people in this country. So for Pacific Islanders, there's a deficit of 200 Pacific Islander physicians for every 100,000 Pacific Islanders. So if we assume our population is 1.6 million, right, which is about what the US Census reported recently, that's a deficit of 1,600 Pacific Islander physicians. We need more people to become health care providers. And I do think that this is a way to help mitigate a lot of the health disparities. 1,600 in this country. It's a remarkable number. Next slide. And this is exemplified by the number of Pacific Islander, Native Hawaiian faculty members in the United States. There's only 161 out of all medical school faculty in the United States, 193,000. There's only 161 as of 2022. And we need more people to become physicians, educators, and help mentor the next generation of Pacific Islander providers. Next. So we developed this program at the University of Utah called the Haumana o Pasifika program, which is designed to give Pacific Islander undergraduate students who are interested in healthcare careers a research experience during the summer so that can bolster their CVs, their resumes, get some publications out of it, in the hope that will, increase their matriculation into medical school, dental school, pharmacy school, nursing school, NPs. And this is honestly one of the most rewarding things that I've ever done in my life, is helping these kids pursue their dreams with ultimate goal that, they'll carry on what people like Ray and others are doing as well. Next slide. This was our class in 2023. We had 8 individuals from all over the US. Many of them were from Utah, but we had kids from the East Coast, the West Coast too. Yeah. Next slide. Ray, can you go next slide?
think we lost him. Let me
Yeah.
see
Yeah,
if
lost
I
Ray.
can go next. What's that?
Who fell victim to technology.
That's the theme of the night.
Here he comes.
Here we go.
Yeah, it's basically my last slide. So these are our 2024 scholars. This is a program that is now funded by the National Institutes of Health. And so we had 8 last year. This year we have 11 coming to Utah for the summer to do research internships.
That's so awesome. That's so awesome.
Yeah, it's pretty fantastic. Next slide. These are the folks who've helped with the research, the Utah Pacific Islander Diabetes Study. Next slide. These are individuals who've been supporters, really of everything, including the research, the efforts to get this research internship program going. Honestly, without the community support, that couldn't have happened. We got letters from over 30 people, 30 CBOs to, help get this funded. So they're instrumental. Next slide. And just again, all those people who provided letters of support and our Haumana scholars. So thank you.
Awesome.
Sorry for the technical difficulties, but
We get through. So it's always interesting and exciting to see the next generation get involved, especially at early ages. That group of of students that are getting in early. Do you see that as a trend? Like, do you think there's
Carl,
going to be?
you guys having this video problem?
What's that?
Is it on my end?
Probably.
We can hear you.
We can hear you.
But do you think that's a trend where we're going to end up getting the younger generation involved early? Because that looks like an exciting cohort.
I mean, we have to, right? Like, I don't know, Carl. Like, I want to get these kids younger, 4th, 5th grade, get them interested in science. You know what I mean? I think there's a lot of just attrition from college, right? Or even like high school. Kids don't even think they can go to college, right? So I want to get them younger. I do think that there is an increasing trend in these sorts of research internships for groups that are underrepresented in medicine. I participated in another one called a Native American Research Internship. That's been going on since I think 2010. And we kind of modeled what we're doing after that. But I think, University of Hawaii has Imi Ho'ola, which is sort of a similar program. But I think the trend is in that direction because there really is a need to diversify the workforce in the United States. And the thing is, there's talent, right? There's smart kids out there, right? And we got to grab them and let them know that you can do this, right? Like, you can do it.
We're involved.
I'm going to stop my camera because the light is
You're fine.
affecting my face, and I'm going to go change the shade. So I'll be right back. But
No problem. No problem.
It's interesting. This plays kind of into NACI, what you and I see with there's a Bay Area nonprofit organization here called PieFest that what they do is engage kids at, like Dr. Kalani had said, we want to get them involved at an early age. There probably are other programs like PieFest that are engaging our younger generations, like Doctor had said, at really young ages, to show them, pictures. And if we don't have a picture of the two of you in those kind of spaces, so they can see that there are doctors and scientists and STEM professionals out there doing it, I think that you're right. That the more exposure they have to somebody who's doing it, the more likely they're going to do and look at it and say, hey, somebody looks like me, a name looks like me, looks like my family. I can try it out. So it's exciting to see. You and Dr. Kalani, you had talked about earlier. Actually, one of the things I'm going to take away, and I wrote it down: chicken katsu's okay every now and then. Dr. Kalani Raphael. I think the key there is every now and then. But you had said earlier that there'd been advances, pharmaceutical advances, for the first time in a while, with the what is it, ESKD. Have you seen the advances, non-pharmaceutical advances in the Pacific Islander community? You list a lot of obstacles or challenges that we face as Pacific Islanders, but do you feel like the community is also advancing, or do you feel like we're still facing like the blockades or the challenges?
Yeah, that's, I don't know, maybe Ray can weigh in on this too. I feel like maybe there's just not enough information that's getting out to the community, and that's kind of why I designed this talk the way that I did. Was, I presume there's going to be, non-medical people who watch it, and maybe they're interested in it for their families, right? But like, this is how I hope to get information out. Like, these are the medications that if I saw Dr. Kalani, but I cannot because I'm in Hawaii and he's not here, he says, talk to my doctor about this, talk to my doctor about that, talk to my doctor about this thing. And maybe that's impactful. But I think it's about information, and it, coming from maybe someone trustworthy. I don't know if that's me, but, I think that's one of the things. I think, in Utah, there's some language barrier, right? With, we have quite a bit of Tongan and Marshallese speaking folks, and that's all. As a provider, it's always a little bit more difficult. But yeah, I don't know, Ray, and I think some of these drugs are actually quite expensive. Like these SGLT2s. They're pretty costly, and not all insurance companies cover them, which is
like that's
crazy, because if they prevent kidney failure, which is so costly, right? Like,
well, that's the challenge,
more
right?
about that.
If there's breakthroughs, then there isn't a generic version, right? So then people, you're going to be paying full ticket, prices, because there's not a chance for the generic version of it.
Yeah.
Obviously, that's much less costly for
Right.
people to get to.
I think there will be some generics of these drugs coming out pretty soon.
Good.
I think so too. Can I ask you a question? For someone like, I get blood work done all the time. Should I worry? Should we if my potassium is higher than 5, should I freak out, or is there something to bring our numbers down? And of course, I 100% believe it's the food that we're eating, and all the bad food that you showed, the Spam and the katsu, you know what I mean? It's so, you work 40 hours a week, right? For you guys, 50, 60 hours. I think the easiest thing is for us to go to a drive-through and quick. But so I was, Spam, that's not really our food, but should I freak out if my potassium is higher than 5, or is there something I can do to bring it down?
The answer is it depends. If you have normal kidney function, most times the potassium being high will be a transient thing. And for the sake of just, I don't want people to take this as medical advice, but if you have a high potassium, talk to your doctor about it, right? That's what I got to say. But, potassium sometimes is falsely high in the blood. So one thing that can happen during a blood draw is the red blood cells can break apart. And when that happens, potassium can leak out into the blood tube, making it look like the potassium's high, but it's actually not. So not all the time is a high potassium really reflective of what's going on in your body, but there are ways to bring it down. Sometimes medications cause the potassium to be high. Kidney function plays a big role in that. So it's kind of hard to say. Definitely over 6 is something to take seriously. When you're kind of in that 5 range, there can be more thinking about it.
Okay, yeah. And then one more question: the ASAH2, that gene.
Yeah.
When we're doing, can we ask for that to see? Get tested.
Too early.
Yeah.
Too early.
It's just research labs, Naki.
Okay.
Yeah,
but you can actually. There's a lot of there's a lot of places that are trying to recruit for genetic, like these broad genetic studies. So you may be able to get it that way. Okay. Because they just do all comer mutations. Actually, but it's not a mutation, right, Kalani? It's an allele.
It's a variant, yeah.
So they may not report it if you have it.
Okay.
Yeah. No, so
it's too early.
Just a couple quick things because I got to run out. But wonderful job, Kalani. That was pretty amazing. There's so many points in there that could have been its own talk by itself. I think it's really important to make sure that we foster this pipeline. That deficit slide was loud, like really, really loud. Yeah. I don't think a lot of people know that there's more. There were more Pacific Islanders in the first round of the NFL draft than that graduated from med school.
Right.
If that's not a clear indicator of where, our social determinants are, that should be. Yeah. The other thing is, I forgot her name. There's a Mokayo, Raya
Mokia.
She's over at Children's Seattle, but she's a pediatric nephrologist. But she's the kind of that future we were talking about, where we need more specialists. We need more general practitioners. We need more specialists. We need more researchers. Just because we have so many things that we need to address. And so we need to do a better job of sort of harnessing this energy. The sphingolipids is a pretty tough place to talk about disorders because those things are so ubiquitous. But I think our hospital is doing stuff on epigenetics and sphingolipids regarding diabetes. Might be something worth looking into if you guys are interested. But anyway, I gotta jump out for my next meeting. Thank you so much, Naki and Carl, for hosting.
No, thank you,
Kalani, thank you so much always for sharing wisdom with us. And then I'll see you guys at the next Grand Rounds, which is next month. I think we're slated to have Patrick Thompson, who'll be reporting on their large-scale rainbow community. I forgot the acronym, but it's basically the Queer and Trans Pacific Islanders from New Zealand. We did a humongous study over there looking at their wellness. So in honor of Pride Month, we're going to have them do the Grand Rounds. Kalani was gracious enough to present during Native Hawaiian Pacific Islander Heritage Month. So
thank you so much, everyone. Have a good evening. Don't forget to send in your code.